After having dealt with the vacuum extraction, now we'll be switching over to another method of assisted vaginal delivery, that is obstetric forceps, and emphasizing upon the low forceps delivery. Obstetric forceps is a double-bladed metal instrument used for extraction of the fetal head. That means there are two blades which hold the head of the fetus and then the head is extracted. So design of the forceps, basically it consists of two crossing branches, that is one and then the second branch will be there, and each branch has got four components, that is the blade, the shank, the lock and the handle. There's a handle to hold the instrument, and each blade, that is this blade, has two curves. One is the cephalic curve, which is abutting the fetal head, and this is the pelvic curve along the pelvic curvature. The history of forceps is very old, and various models of forceps have come since then, and some of them are still persisting and some of them have been abandoned now. So some of the important types of the forceps include the long curve obstetric forceps, which are a log and extraction also here, not being used nowadays. And the wriggling forceps, this is the Wrigley's forceps. This is the most common of forceps being used nowadays, used for outlet forceps delivery. Then this is the keel end forceps. There is no lock over here, it slides over each other, and this was used for the mid forceps delivery and for the rotation of the head. Then the Piper's forceps. This is used for the extraction of the aftercoming head of the breech, and the Barton's forceps was used in the occipital transverse position is there, and during the delivery during cesarean. So again, coming to the same chart as we had dealt with the assisted vaginal delivery, that is outlet and low forceps, depending upon the station of the head. These are two being used. Mostly the outlet forceps is being used, the details of which we have already dealt with. So indication of forceps delivery is almost the same as that of the vacuum. That is a prolonged stage of labor for more than 2 hours in primary gravity and 1 hour in multipara. This is the time duration if the epidural analgesia is not used. If the epidural analgesia is used, then it becomes 3 hours for primary gravity and 2 hours for multipara, because the expulsion force is hampered during the epidural analgesia. So this prolonged labor may be due to inertia and poor voluntary bearing down. There may be large fetus, rigid perineum, and malpositions like persistent occipito-posterior positions and deep transverse arrest. However, for these deep transverse arrest, we are not using the forceps nowadays. Patient is straight away taken up for cesarean section. Maternal indications: maternal distress manifested by exhaustion, tachycardia, temperature being more than 38 degrees centigrade. If there are signs of dehydration, there are certain maternal diseases like cardiac disease, pulmonary tuberculosis, preeclampsia and eclampsia are some of the maternal indications. And prophylactic forceps can be used in cases of medical disorders, VBAC and preterm baby. Then the forceps delivery, there are the fetal indications like fetal distress, prolapse pulsating cord, preterm delivery, after coming head in the breech delivery, and during cesarean section, and used as a vectis or liver. The two blades may be used to extract the head through the uterine incision. Contraindications include unengaged head, cephalopelvic disproportion, malpresentations like face and brow, cervix not completely dilated, inability to define the position of the fetus, and the fetal problems like bleeding disorders and osteogenesis imperfecta. Prerequisites for forceps application, the same as that of the vacuum delivery. The other factors include like anesthesia, it can be general, epidural, spinal or pudendal block, or even perineal infiltration. So since we are doing mostly low forceps delivery nowadays, or outlet forceps delivery, usually the perineal infiltration suffices. In some cases, pudendal block will be required. Then the prerequisites also should include adequate pelvic outlet, aseptic measures one should use, bladder and bowel should be empty, contractions of the uterus should be present, because along with the uterine contraction there will be protraction, and the cervix should be fully dilated and head should be engaged. And then the forewater rupture should be there, and favorable positions and presentations like occipito-posterior and anterior. Face presentation, we are not using the forceps nowadays. So types of forceps application. There is a way in which the forceps are applied over the fetal head. One is cephalic application, where the forceps is applied on the sides of the fetal head in the mentovertical diameter, so injury of the fetal face, eyes and facial nerve is avoided. The second application is pelvic application. The forceps is applied along the maternal pelvic wall, irrespective of the position of the fetal head. It is easier for application but carries a great risk for the fetal injuries, because on the head it will not be applied properly. Then cephalopelvic application. This is the ideal application and possible when the occiput is directly anterior or posterior, or in direct mento-posterior position. So this is the cephalic application, and this is applied along with the according to the pelvic curvature, that is the pelvic application, and this is the proper application when the head is in the direct anteroposterior position, that is persistent or persistent occipito-posterior position. Then this is the ideal one. It encompasses both the cephalic application and pelvic application. So function of the forceps, the traction force, that is the traction is the main component of the forceps function. So the traction force required in primary gravity it is 20 kg, and in multis it is usually 13 kilograms. Rotation of the head, nowadays it's not done. Earlier it used to be done by keel and forceps. Forceps also acts as a protective cage for the head, and from the pressure of the birth canal, so especially in premature babies it is useful. Then it can be used for controlled delivery of the aftercoming head. And one forceps blade may be used as vectors during cesarean section, and the compression effect of the forceps on the cranium is minimal when properly applied. So one should know which one is the right blade and the left blade, especially important in mid-pelvic application, also to some extent in low forceps and outlet forceps application. Putting in consideration the measure in the lithotomy position, the blade will be applied with a pelvic curve directed anteriorly and a cephalic curve directed medially. If the blade will be applied to the left maternal side, it is the left blade, and vice versa. So the low forceps application which we are dealing. So anesthesia can be pudendal block, or sometimes only perineal infiltration suffices. Catheterization to keep the bladder empty, and one should do internal examination, proper internal examination, to assess various factors before the forceps is applied. That is the state of the cervix, status of the membranes, presentation and position of the head, assessment of the pelvic outlet, that is sacrococcygeal plateau, transverse diameter of the outlet, and subpubic arch. These are all to be assessed before the forceps is applied. Then episiotomy is done during the traction when the perineum becomes bulged and thinned out by the advancing head. The steps in the application of the low forceps is the identification of the blades and their application, then the locking of the blades, then comes the traction, and then at the end it is the removal of the blade once the head comes out. So this is the choosing of the left blade. Then the left blade is applied. We'll come to the description later. Then this is applied and kept on the left side of the patient. Then this is the application of the right blade. Then once both the blades are applied, the right blade being above, then the blades are locked. Then the gentle traction is given with an episiotomy at the time of crowning, and the correct cephalic application has been done over here. And then this is the mento-vertical line. So this can be the segmentum and the vertical line, and this is the correct way of application. And the same thing we'll be dealing in little detail. So in the forceps, the left blade is applied first. It's held by its handle between the thumb and the fingers of the left hand, almost parallel with the right inguinal ligament, and passed along the left side of the maternal pelvis between the guiding palm of the right hand and the fetal head. So as the blade passes into the birth canal, the handle is carried backwards towards the midline. It is now the lower blade after it is properly applied. So then the fingers of the left hand are introduced along the right side of the pelvis, and the right blade is held and passed in the same manner as described earlier. Now this becomes the upper blade. So the two blades now should be locked, and we should be able to lock them easily. If not, then this means that they were not correctly applied and should be removed and reassess the position of the head. So when correctly applied, that is the bimalar biparietal placement, the blade should be articulated with ease. Minor difficulty in locking can be corrected by depressing the handles on the perineum. In case of major difficulty, the blade should be removed. The handle should never be forced to lock them. The clinical check for correct forceps application: the sagittal suture should lie in the midline of the shank. The operator cannot place more than one finger between the fenestration of the blade and the fetal head, and the posterior fontanelle is not more than 1 finger breadth along the plane of the shanks. And this also we should see, it is in the parallel to the lambdoid sutures over here. And the sagittal suture should be perpendicular to the plane of the shank and equidistant from the two blades. And a small part of the fenestration of the blade may be felt on either side after the same blades are locked. So when correctly applied, the forceps grasp the head in the occipito-mental diameter. In the occipito anterior position, the major part of the blade is on the fetal face. So traction. Before traction, again it should be emphasized that there should be easy locking. Blades are equidistant from the lambdoid suture, again emphasized over here, and there is a firm gripping of the head on the biparietal diameter. So traction should be gentle by the force of the arm only. It should be intermittent along with the uterine contraction only. And the two blades are unlocked between contraction, can be unlocked to minimize the period of head compression. So direction of the pull is also important. It corresponds to the axis of the birth canal. In low forceps, depending on the station of the head, the direction of the pull is downwards and backwards until the head comes on the perineum. Then the pull is then directed horizontally, straight towards the operator. And then the direction is gradually changed to upwards and forwards towards the mother's abdomen to deliver the head by extension. So in the outlet forceps, then this takes from here, that is, the pull is first horizontal and straight towards the operator, and then it changes to upwards and forwards. So once the head is delivered by extension, the blades are removed one after the other, first the right one and then the left one, again then the opposite direction in which they were introduced earlier. And then there is a term like trial forceps, the same which we discussed earlier. That means apply forceps in an operating room setup and prepare to abandon the procedure and opt for abdominal delivery in the event of the least difficulty. So another term is failed forceps, when difficulty is not anticipated in forceps delivery but the attempt fails. And this forceps delivery should be abandoned in the following circumstances. That is, if there is difficulty in application of the blade, there is no progressive descent with the moderate traction, and delivery is not imminent after the 3 pulls. So causes, these are the various causes. That is cephalopelvic disproportion, contracted outlet, incomplete cervical dilatation, head not being engaged, some of the malpositions, and fetal congenital anomalies can be responsible for this. So again we have to reassess, and then the forceps is removed and the patient is re-examined to detect any cause and correct if possible, or one can take to straight to caesarean section if there are uncorrectable causes such as cephalopelvic disproportion of the contracted outlet. Exploration of the birth canal should be done for any injuries. Then there is a term called sequential instrumental delivery. The most common type is forceps delivery following a failed attempt at vacuum extraction. One should exercise caution in its use. So maternal complications, immediate complications being injury to various structures like vaginal lacerations, cervical tears. Sometimes the injury can extend up to the fornices also. Then the nerve injury, then postpartum hemorrhage. It can be both atonic and traumatic. Then the puerperal sepsis and maternal morbidity and anesthetic complications also can be there. Remote complications include painful perineal tears, dyspareunia, low backache, genital prolapse, stress urinary incontinence, anal sphincter dysfunction, genitourinary fistulae. So fetal complications, immediately it can be asphyxia, intracranial hemorrhage, rupture of the great vein of Galen, cephalhematoma, facial bruising, facial palsy, trauma to face, eyes or scalp, and if the blades are not applied properly, skull fractures, cervical spinal injury is in rotational forceps. So nowadays we are not using any rotation. Then the remote complications include cerebral or spastic palsy due to residual cerebral injury. So which one is better, forceps or vacuum? There are certain advantages of each. So vacuum extraction, like it is technically easy to perform and can handle malrotation to some extent and low maternal birth canal injuries. However, it has got a weak pulling power and suction sometimes fails. And in forceps delivery, advantages that it can be delivered in a short time and has got a strong pulling power. Delivery of the fetus is more reliable than the vacuum and be performed even when the caput succedaneum being there. However, it requires experience for technical proficiency, high risk of injury to birth canal as well as to the fetal skull. Thank you.